I'm Louis. I'm a doctor in the UK, but I'm originally from Syria. What we've put together today for you is this tutorial on how to read chest x-rays. Oh, we've got some more people signing in, that's good. So I think we're going to start off with just going through a bit of explanation about what it is you're looking at when you see a chest x-ray. And then we'll go through the different kind of problems that you can find when you're looking at chest x-rays. And the most important thing is we're going to have a system for how to go through the x-ray in a systematic way so that you don't miss anything when you're looking at x-rays. So just to double check to the new arrivals, if you can hear me well, can you just type in the chat box on the right hand side that you can hear me? And then we'll start going through everything. Perfect. Alright, so first thing you need to understand about chest x-rays is what it is we're actually looking at. And the way a chest x-ray is taken is you get a patient to stand up in front of an x-ray film, and behind them, from their back, you fire a beam of x-rays which go through their chest and then cause a projection to be projected onto the film. And that means you can tell a lot of information from the patient by the fact that they could stand up to have the chest x-ray, so they must be quite well. If the patient's very unwell, they can do something else, which is called an anterior-posterior chest x-ray, which means that if the patient can't stand up, you can put the plate behind their back and then take the x-ray that way, and that again tells you information about the fact the patient was unwell. So before you even start, you kind of get a feel of how sick your patient's going to be. But if we start going through what it is you're looking at, the first thing we need to understand is the anatomy of what we're looking at. So this is a normal chest x-ray that's been taken with a patient standing up, and the x-ray beams come from behind and it's been projected onto a film on the front. So the different components of the x-ray are the lung fields. So these are where the lungs sit, and they're dark because of the fact that air is very easy for the x-rays to go through air. And in healthy lungs, a normal anatomy is that you have a superior lobe on the left and an inferior lobe, and on the right you have a superior, a middle, and an inferior lobe. But on a chest x-ray, you can't see those different lobes, so what we do instead is we do imaginary divisions, and we call the different fields the superior zones, the middle zones, and the inferior zones. So those are just imaginary divisions that mean that when we talk about something, we can say there's a problem in the right inferior zone on the chest x-ray, and that means it draws everyone's attention to the section of the x-ray that you're looking at. The next important thing to be able to notice is the trachea. So this is the windpipe. This is where air comes in through the mouth, and the air comes in, splits into the two branches and goes into the lungs. So if you see it outlined here, this is the trachea, and again it's dark because it's filled with air. So it's a very important thing to be able to spot on the x-ray. The next thing after trachea is the heart shadow. So this area is the heart, and you can see it very clearly on the x-ray. The next thing to be able to recognize is the aorta. So this is the vessel that when the heart pumps, all the blood comes into the aorta and then gets distributed to the rest of the body. And this very big vessel here, you can see on the chest x-ray, just comes up, and that's a healthy person's aorta that you can see coming out of the heart and going to supply the rest of their body. And the last thing to be able to spot is this. It's called the hilum. And what the hilum is this is the vessels, the pulmonary arteries, and the lungs that they need and take the blood back from the lungs to the heart. So that's the hilum here. You can see it just marked out like this. So those are all the anatomy sections: the trachea, which is the windpipe, the heart, the aorta that takes the blood from the heart to the rest of the body, and the hilum, the hila, which take blood to the lungs and from the lungs to the heart. Does that all make sense so far? Are there any questions about the anatomy of what we're looking at when we look at a chest x-ray before we start going into problems that you can find? If you have any questions, just type them in the box on the right hand side. Okay. It takes a bit of time to get your head around all of these things, but we'll come through it a lot of times. So after a while, you'll start to get used to it. But it's just as long as you understand what the main things in the middle of the X-ray are. So it's the heart, the trachea, the big blood vessel, the aorta, and the vessels to the lungs. And as we go through lots of different chest X-rays, eventually it will become a lot more easy to spot. Yep, the hilum, it's spelt like this, hilum. They contain the pulmonary arteries and the pulmonary veins. That's correct. Okay, so the first thing you do when you look at a chest X-ray is you make sure that you're looking at the correct chest X-ray. So the way that you look at a correct chest X-ray, we just got another person signed in. Let's just make sure their sound is working. Hi, Alexi. If you can hear us, just type a message in the chat box on the right, and we'll make sure your sound's all connected. You've got to make sure you turn on your speakers as well. Excellent. So if you can hear us, Alexi, we've just been going through some of the anatomy of the lungs, but we'll come back to that in a second. At the end, we'll go through the anatomy we just showed if you've missed it, but for the time being, we'll just keep going with what we've been doing. So when you start looking at a chest X-ray, you have to make sure you're looking at the correct patient. So you have to check the technical details that you'll see up here in the corner about the X-ray that you're looking at. So you make sure it's identified with the correct patient's name, date of birth, and if your hospital uses hospital numbers, then the correct identifier. Then you need to check whether it's a PA chest X-ray, and what that means, it's from posterior to anterior. So it means the X-ray beam was at the back, and it was fired from somebody standing up, and so that means the person is well enough to stand up. If it's an AP X-ray, that means it was taken when the person was lying down in bed. It means they're too sick to stand up. And the reason that's important is because sometimes the heart can look a bit bigger when it's done with somebody lying down. So you just have to be able to recognize that. But these are all sort of technical things which, as you go through X-rays, become much more easy to understand later on. So for the time being, it's just to be aware of those things, and we'll go into them in more detail later. The next thing to do is make sure the chest X-ray is in the correct position. And that means you have to be able to see what we call the apex of the lung at the top, and what we call the costophrenic angle at the bottom. So the whole lung field, from top to bottom on both sides, is inside the picture. If any of it has been cut out, then it means it's an inadequate X-ray. The person who took it hasn't taken a correct picture, and you need to get another X-ray to make sure that you don't miss anything. So being sure you can recognize the position is very important. Then you have to check that the patient's taken a correct inspiration. So when they have the X-ray done, they're asked to take a deep breath in, and so if you see, we'll draw here. These are the different ribs. That's rib 1. This is rib 2. This is rib 3. This is rib 4. Rib 5. And rib 6. The important thing to notice is rib 6 cuts halfway across the diaphragm, like this. So you can see this is rib 6 marked out like this, and it intersects the diaphragm halfway. That tells you the patient has taken a good inspiration, and that that's a correct picture. If, say, the diaphragm level was up here, then that wouldn't be a good inspiration, and you would know that that patient hasn't taken, won't be able to read the chest X-ray properly. The next thing you need to check is rotation, and so what that means is, was the patient facing the beam correctly when they took the chest X-ray? So if they were rotated off to one side, you might not be able to see things properly. And the way you do that is you find their clavicles, which is the collarbone. So this is the collarbone. You find it on both sides. So they're collarbones. And if you look between the collarbones, you can see these, which are the transverse processes of the spine. So this is the bit that you feel if you run your hand down your back, the spiky bits of your spine. That's these things here. And they should be halfway between the two clavicles. They should be in the middle, in the center. Equal distance between both clavicles and the spinous processes. That means the patient was facing head-on and they weren't rotated. If the spinous processes were here, for example, then that would mean the patient is rotated at an angle. And the last thing is just the penetration, which means that enough of the x-rays went through the patient onto the film so that you could see all the picture correctly. And the way you do that is you look behind the heart to see if you can make out the vertebral columns. So this is the spinal columns, each one of the different blocks. And if you can, you should just about be able to see them behind the heart. And that tells you that there's been a good enough penetration that you can see everything through the patient's body properly. So these are the vertebral columns. So if you can see those, then it's been a good penetration. So does that all make sense about the technical details? That's the slightly boring stuff, but it's important to be able to understand so that you know that the x-ray you're looking at can be interpreted properly. But once you've done that, you can go and look onto the different pathologies and the different problems you can find in x-rays. Does everyone understand that so far? Are there any questions about technical details or about the anatomy? No questions? Good. All right. So now this is the fun bit. So going through the system of how you approach a chest x-ray. And the reason it's so important to have a system is because if, say, there's a really big pathology somewhere in a chest x-ray, you see something really obvious and massive, there's nothing on this chest x-ray, but for example, you had then all your attention will be focused on the big problem, and you might miss the little problem somewhere else. So if you always go through a system, that means you won't get distracted by the big obvious thing. You'll always find all the problems on the x-ray rather than missing anything. So the key to having a system is that you don't miss things. And what I'll do is I'll quickly run through a very good system to use. This is something we use in England a lot. And then once we've gone through the system as an overall view, we'll go through each point in turn and look at the different problems you can find at each step. Okay? So the first thing you look at is, are there any foreign bodies on the x-ray? And what we mean by foreign bodies is something that isn't part of the patient's body. So are there any medical devices, any lines or tubes, any things that the patient has swallowed, or anything really obvious that's metal or plastic that clearly isn't part of the patient's body? So you look through the x-ray and look for those first. The next thing you do is you look at the trachea. Remember, we showed those pictures of the anatomy of the trachea, but we'll come back to that later. So you look at this dark part of the patient's trachea to make sure that you can't see any pathologies or any problems with the trachea that we'll see in a minute. The next thing is we look at this part of the chest x-ray, which is called the mediastinum. So this is the mediastinum here, and the main things that are in the mediastinum is the aorta that we saw earlier, the big vessel that takes the blood out of the heart to the rest of the body, and also something called the thymus gland, which we can come to afterwards, but that's a big gland that sits at the front of the chest that sometimes can be important in patients with lymphoma. But all you need to do when you start looking at chest x-rays is just to be able to recognize that this is what a normal hilum looks like, and be able to spot when something looks wrong with this bit, and we'll see pictures of when this bit looks wrong. Once you've spotted that something is wrong, then you can show somebody senior and they can try and work out what the problem is. The most important thing is not missing that there is something wrong when you're looking at the mediastinum. The second part is the cardiac shadow, so the heart here, which again we saw before, so checking the heart angle. So it's just very simple. You start from the top and you work your way down. 1 trachea, 2 mediastinum, 3 the heart. And then you just do the same further over to the other side of the chest. So work your way down again. The next thing we look at is the lung fields. And when you look at lung fields, by lung field I mean this whole black area, all of this section of lung, and this whole black area here. When we look at the lung fields, you always compare left with right. So you look at the upper zone on the left and you compare it to the upper zone on the right. Do they look about the same? Is there anything really obvious that you can see, any dark bits, any light bits? You look at the middle zone on the left and the right, and then you look at the lower zone on the left and the right. Then you work your way down to the hilum. So this is what we call the hilum, as we mentioned. This is the vessels for the lungs, and you look to see if they look normal, and we'll go through some problems you can spot with those as well later. And then you go to look at the diaphragms. And the key thing, you're looking at the diaphragm, should have a nice rounded shape like this, should have nice clear edges, and there shouldn't be any air. It's all nice and solid. There's no black lines of air. It's all really solid. And we'll show pictures of what it looks like when you get air trapped under there and what that means later. So as we said, start at the top. 1 trachea, 2 mediastinum, 3 look at the heart, then start at the top again. Look at the lung fields all the way across, look at the hilums, and then look underneath the diaphragm. Next, we go to look at these, which are called the costophrenic angles. And what that basically means is the angle between the rib cage, or the chest wall, and the diaphragm, this angle here. And you can see that it's a really sharp angle. The thing you have to look out for is to make sure that that point is not blunted. If it starts to look blunted, then that tells you things about if there's fluid collected, and we'll see what a blunted hilum looks like shortly. Once you've looked at the angles, the next thing you look at is called the pleura. And the pleura is the lining on the lung, on the outside edge. And what it basically means on a chest x-ray is we're looking at the connection of where the lung touches the chest wall. You can see it makes a nice, neat connection on a healthy person's. This is a healthy chest x-ray. There's no big black areas where there's air trapped. You can't see the lung coming away from the chest wall. It all looks nice and clean. And we'll see some problems that can happen when you get air trapped outside the pleura in a minute. And the last thing that you look at on our system is you look at the bones and the soft tissues. So you check all the different bones to see the clavicle, the ribs, are there any breaks, is there any air trapped inside, and the reason we check that is because sometimes if you're focusing all your attention on the lung, you might miss the really obvious clavicle break or the really obvious broken ribs. So it's important, again, it's important why we have that part of our system, that if you do these 9 things, start at the top, work your way down, then even if, say, at number 3 you find a big problem, you'll keep going with the rest of your system, and that way you'll also find any other problems at the same time. So that's the overall system, and what we'll do now is we'll go through each one of those points in turn and look at some problems that can happen. Are there any questions so far about the system or anything that doesn't make sense yet? Everyone seems scared to type things. Yeah, that's good. It needs to be interactive, so you have to ask us any things that you have questions about. Just let us know and we'll go through all of those. But good. It's really easy to spot a foreign body because they look really strange. So this isn't a real chest x-ray. This is, if you've seen the film Iron Man, that guy has a big sort of power plant in his chest. And the reason this is a good slide is that if, say, he was a real person and had a real chest x-ray, you can see how really crystal clear white this is, and it's completely perfectly spherical. Everything about it is clearly something that you don't get in a real human being. The fact that it's perfectly white means it's probably metal, and a normal person, its soft tissues are a bit grayer. So this is clearly something that is not part of the human body. This is a foreign object. So this is Iron Man's chest x-ray. So you're not going to see anything like this, but what you will see are things like this. This is a real chest x-ray for a real patient. And does anyone know what this is? If you think you understand or recognize what this device is on this patient's chest x-ray, then type it on the box and we'll see. A mouse. A pacemaker. Yeah. So those are the options. That's exactly what this is. And what a pacemaker does is it's an electric device that you surgically implant in the chest wall, and it has these leads, and these leads go into the chest and into the heart, and they create an electrical current that stimulates the heart. So this is for exactly arrhythmia corrections for people who have problems with the way their heart is pumping and the way it's conducting electricity. Then you can implant these pacemakers in, and it will keep their heart pumping at a regular rhythm. So this is a pacemaker. That's something you'll often see in a chest x-ray. It's a foreign body. Next foreign body is this. So this is a little bit tricky if you haven't seen many x-rays before. Can anyone spot the foreign body that's on this x-ray? So something that's not part of the patient's body. Doesn't matter if you guessed wrong. So guessing is part of the process. If you guess something and you get it wrong, then it makes it stick better with you. So we're looking for foreign bodies. We'll come to look at the heart size when we do the heart section in a second. So you can look around the heart. It's near the heart, the problem. It's not a problem, but it's something that we've done to the patient. So if you look here, can you see this really white tube? There's a really white tube that's coming all the way down here, and it runs along like this. Can you all see that? Yeah, so this white tube, what that is something called a nasogastric tube. And a nasogastric tube is a feeding tube. And it goes into the stomach, and it means if the patient's got a problem with swallowing, then they won't be able, then it bypasses that and means you can get food directly into their stomach. And the way to correctly check the reason we do chest x-rays for people who've had nasogastric tubes is when you put the tube down their nose, there's a risk that you can put it into the lung instead of into the stomach. And that's incredibly dangerous, because if you do put the tube into their lung and you don't realize without doing a chest x-ray, then when you start feeding them, all of the food is going to go into their lung, and that will cause a pneumonia and most likely kill the patient. So it's really, really important to be able to, because if you feed through an NG tube that's in their lung, then it's a very good chance you could kill that patient, and that's a really dangerous thing to do. So this is why seeing foreign bodies on chest x-rays is so important. So say you've put this NG tube into the patient, and then you've had a chest x-ray to check it's confirmed in the right place. The way that you confirm it is you follow the path of the tube, and it should go straight down the middle of the chest before it goes off to the left-hand side where the stomach sits. So can you see this bubble? This is what we call the gastric bubble, and this is just some air that's inside the stomach. So the stomach is sitting in this bit here. This is all stomach across here. You see it like that. And what you need to be able to check is that the NG tube goes straight down the center. If I mark the trachea, you can see that that is the trachea. And if I mark the NG tube, you can see the NG tube goes behind it through the esophagus, and then comes straight down the bifurcation, and then goes into the lungs, into the stomach. If this tube, instead of going straight down, if what it did, if instead of going straight down, it went across, out like this, down one of the bronchi, or it went down this side, then you would know that it's in the lung, and that needs to come out immediately as an emergency, and no one should put any food down it, because if they do, then you'll kill that patient. So this is a picture of another nasogastric tube. It's a bit easier to see this time, but you can see this time that the tube is in the wrong place. So this is the bit of the tube that's outside the patient's body, and this is sitting outside him on his chest, and then it goes up into his nose. You can't see that part. It goes down through his nose into what the person putting it in thought was his esophagus, but in reality they put it into his trachea, into his windpipe. And then you can see, instead of coming the way it should have come, the way it should have come with the old x-ray, where it should have come down here into the stomach, what it does instead is it comes down, goes through the trachea, and into the lung. So this now is sitting inside the lung, that tube. So this, if this patient was fed through this NG tube, then they would possibly be killed. So it's really important that you spot that this is clearly in the wrong place. So if I draw out the trachea as well, it makes it more easy to see. So you can see this is the trachea, the windpipe, coming through like this. And the tube clearly goes right down through the trachea into the right main bronchus and into the lung. Can you see that? It should come down here into the stomach, but it's not doing that. And here is another picture of an NG tube that is in the wrong place. So you can see it should have come straight the way down and into the stomach, but instead what it has done, it's come through into the right main bronchus. It's actually been pushed really hard, so it's looped around, and then it's come back through and then gone down the left bronchus and is sitting inside the lung. So this NG tube is again sitting on the other side of this patient's lung. So does that make sense to everyone? Is there any questions about NG tubes, the nasogastric tubes and their positioning? Perfect. All right. So after we've looked at foreign bodies, the next thing is to look at the trachea like we mentioned earlier. So, as we highlighted, this is the trachea. So can everyone see that dark area? That dark section is the trachea. So that's your windpipe that splits into the two bronchi that then become bronchioles and supply the rest of the lung with air. And what the most important thing about the trachea to spot, other than when we were looking at tubes that are going into it, is that it's in the middle. So you can see it does go to the right a little bit. That's okay because in most people's anatomy, nothing's quite perfect. Everything's a little bit off center. But you're right in looking to see if it's in the middle is very important. So you can see it is roughly in the middle. It's a bit off. It's not perfect, but it's basically. So as we talked about before, these are the spinous processes. This is the spine. So this is right in the middle of the patient, and it's not perfect, but it's pretty close to the middle. So that's a normal trachea, that position. What you do need to spot is something like this, where the trachea is really deviated. So I'll highlight the trachea for you. That is the trachea. So you can see it should be coming down here, nice and neat and splitting off. But instead, it's all been shifted well off to the side, like that. So if we compare this picture, so this is where our trachea should be. That's our normal trachea. And this trachea has all been pushed right up off over here. And what Alexia has written, a tension pneumothorax, is exactly correct. So this is a picture of a tension pneumothorax, which again is another medical emergency. This patient, again, this picture, this sort of tension pneumothorax we call it, what it means is that air has leaked out of the patient's lung into the chest wall and is filling up the chest wall and making this part of the chest get really high pressure, and it's pushing the other lung. It's pushing the lung into a little collapsed ball across here, and it's pushing all the heart and the trachea and all the other sort of organs in the chest off to the left-hand side, so the right-hand side. And that means it's becoming very difficult for the patient to breathe, it's becoming very difficult for the heart to pump, and patients with this will die within minutes unless something is done to correct them. And in theory, these patients shouldn't even have chest x-rays because you should be able to pick it up from the clinical picture, just from the symptoms and things they've been having, and from examining them, you should spot this. And then you need to manage it within minutes before they have a chest x-ray because it's such a big emergency. And the way you manage it is you put a needle into their chest. It's called a needle thoracotomy, and that lets all the air escape, and it lets the lung re-expand, and it lets the patient breathe again so that they survive. We do an emergency lecture presentation later on. We might do that in a couple of weeks, where it goes through how to manage this emergency and where you put the needle and how to diagnose it and all those sort of things. But the main thing is, again, on this shifted off to the side. It either means something like in this case is pushing it, or the air is pushing it on this direction, or if you've got a collapse of the lung on the other side, it can pull it in the opposite direction as well. But again, it's all about recognizing the trachea is not in the right place. And once you've spotted that, the next stage is to kind of look into why that might have been. So that's the trachea, nice and easy. The next one is the mediastinum. So we said the mediastinum is this middle bit of the chest x-ray here, where the aorta sits and where the thymus gland sits. And this is a picture of a normal person's aorta. We can see there, highlighted there. And this is an abnormal aorta. So this is somebody, if you can see, instead of having our nice, neat, crisp aorta like this, where it all comes across and is nice and compact. What it does instead is this massive aorta that's coming round. So you have your heart here, and then it comes through, and this big swollen aorta is all coming out. And what this is an aortic aneurysm. So an aneurysm is a dilation, a swelling of the vessel. So this person's got a thoracic aneurysm, which is dangerous because these can burst or can dissect. And so this is something that will require surgery at some stage to stop the patient from having a aortic dissection or a bleed into their chest. So the next thing on our system, we've done trachea, we've done mediastinum, and now we look at the heart, the cardiac shadow, the heart. And there's basically two things you need to spot on the heart. The first is you should check to see these are nice, clear heart borders. You can see the borders of the heart nice and clearly. It looks like a triangle, a sail sometimes people call it. So it's a nice triangular, crisp border. This is air, and this is heart. And the heart blocks the x-rays a lot more than the air does. So it's a very clear distinction where the heart shadow is. The other thing to look at is the size of the heart. And the heart width in a normal, healthy person should always be less than the width of the chest wall. So what we mean by that is this is the width of the chest wall, and this is the width of the heart, and the heart width should be less than half the width of the chest, and that's called the cardiothoracic ratio. And the name doesn't really matter, it's just a case of you should always check to see is the heart smaller than half the width of the chest. If it's bigger than half the width of the chest, then that's cardiomegaly. It means the patient's heart is too big, normally because of something like heart failure. So this is a good picture of cardiomegaly. You can see the width between here to here, this is the width of this patient's heart, is significantly bigger than the width of the chest, half the width of the chest. So it's over half the width, and that means cardiomegaly. It's important that you can only make this diagnosis on a PA chest x-ray. So if somebody, like we mentioned at the beginning, is standing up with the x-ray beam coming from behind, because if they're lying down and on a bed and you do an AP x-ray, then sometimes the heart can look bigger just because of the way the x-ray is taken. And so it looks artificially big even though it's not really big. But in this patient, this is a normal x-ray, so this person's heart is bigger than half the width of the thorax, therefore it's cardiomegaly. Right, so that's the first three sections. Trachea, mediastinum, and heart. Any questions about any of that so far before we move on to the next bits? Good, okay. So, the next bit we look at on the chest x-ray is the lung fields. And as we talked about before, you always compare the lung with the left lung, and you divide it into zones. So you look at the upper zones and you compare the two, look at the middle zones, compare the two, and look at the bottom zones and compare the two. Right, so Ali's asked how can we make a difference between, how can we differentiate between the pericardium or heart megaly? So that's true. In pericardial inflammation, you get something called pericarditis. The pericardium is the lining that sits around the heart, and that can get inflamed, and that can look big on a chest x-ray. And it can look very similar to cardiomegaly, which is the big heart on the chest x-ray. In reality, they both do look very similar. With pericarditis, which is inflammation of the pericardium, you get something called a globular heart, which I'll go back and just quickly show you. It looks quite similar to cardiomegaly, but it looks a bit rounder. So if we put up our picture of cardiomegaly, which is just here. So if you look at this picture of cardiomegaly, it looks like a big heart, but it's still got a kind of normal heart shape. It's swollen, but it looks like a heart. In pericarditis, it can look very similar. It can be very hard to distinguish the two on a chest x-ray. That's why you take the whole picture into account. But in pericarditis, you tend to get something that looks a bit more like this, a globular heart. It looks like a globe, so it looks like a big ball. So in pericarditis, you tend to get a globular ball-like heart, whereas in cardiomegaly, you get a big heart-shaped heart. But you can't really distinguish the two on a chest x-ray. You need to distinguish them on the clinical kind of picture of everything about the patient. So it's very hard on a chest x-ray. that make sense? Good. Right, so the lung fields. Let's start with this picture. So, does anyone want to have a guess where is the pathology in this patient's lung field? So we're looking at the lung fields. Is it on the right? In fact, what I'll do, I'll put up a little poll for you. So, is the problem on the right or the left? You should be able to see options on your screen now, so you can click to say if it's right or left. So click to say where you think the problem is. Yep, that's good. Good. So I'll publish the results. So all of you think that the problem is on the right-hand side. And is it on the upper, middle, or lower zones? So is the problem in the upper zones? And oops, sorry, just undo that. Is the problem in the upper zones, the middle zone, or in the lower zone? Good. So everyone spotted it, that means. That's excellent. So we've got everyone saying the problem is in the right middle zone, which is this section. And if you've not been able to see it yet, that's okay. The problem is right here. And this is something called a coin lesion. And the way you spot it, like we said, you compare right with left. So if you look up here, this part of the lung with this part of the lung, they look kind of similar. Then if you look to this part of the lung to this part of the lung, clearly there's a big difference here. You've got this nice sort of clear, darker area. And here you've got this round opacity that you don't have on the other side. So there's clearly an asymmetry. And asymmetry is something very important to help you pick up things. And as you keep going through the rest of the lung fields, the rest of it looks kind of the same. But you've clearly got this well circumscribed, we call. That means it's got a nice clear edge. There's a clear edged lesion, and this is called a coin lesion because it looks like there's a coin in the patient's chest. And there are quite a few things that lesions, but the most important three top differential diagnoses for a coin lesion is a tumor. So this could be a cancer, a big tumorous growth here. An abscess, which is a ball of pus, a ball of inflammation caused by an infection. Or a granuloma, which is another ball of inflammation that's caused by an autoimmune process or an inflammatory process, not an infection. So those are the top three that you think of. So your differential diagnosis when you see a coin lesion, which is a little round circle like this, is a tumor, a cancer, or an abscess, which is an infection, or a granuloma, which is a ball of inflammation. So good. Nodular enlargement. Do you mean to do with these bits, the nodes? Is this what you mean? Yep, so that's a good thing to look for. Whenever you see a ball like this, because it could be a tumor, tumors often spread to the hilum, because that's where the lymph nodes, because when the lymph tissue is drained, it goes into the heart, it drains through the lymph nodes into the lymphatic system, and so cancers often spread to the lymph nodes, and cancer in the chest often spread to the hilar lymph nodes. And so you can get hilar enlargement. It's a bit tricky to spot on a chest X-ray, which is why you need to use things like CT scans and PET scans, where they can look at the lymph nodes properly. But in this case, it can just be hilar are often very different in different people. It can be difficult to distinguish between big nodes and sort of normal nodes, but it's possible. There's a bit of shadowing and things here, but it's not something you would be able to tell on a chest X-ray. You need a CT scan for that. These hilar without this lobe, if you didn't have this coin lesion here, then these hilar could be pretty normal. You wouldn't necessarily say there's anything obviously wrong with them. But it's a very good thought. You should always look for lymph nodes along the hilum when you see a cancerous cell. So this chest X-ray, again, we're still looking at the lung fields here, so we haven't looked Good. So it does. So emphysema. What emphysema is? The other name for that is COPD, or chronic obstructive pulmonary disease. That's the modern name for a type of emphysema. What that means is, say if a patient has been smoking their whole life, and all the cells and things of their lungs, the tissue has been kind of damaged and decayed over time. Instead of there being lots of nice healthy tissue, it's all died away, so it's all now just lots of air. So you can see it's really dark. If you compare it with the last chest x-ray, you can see lots of tissue and lots of bits of lung inside the x-ray. Here, there's hardly any lung. It's almost like it's just air. So if you look outside, this is all black because this is air just outside. It almost looks the same because there's not much tissue. It's all just filled with empty air spaces. And this is somebody who's been smoking. That's very good. The diaphragm does look abnormal. So the other thing there are three main things that tell you this is emphysema. The first is it's really dark and it's very basically see-through. The second thing is the diaphragms. If you remember, if we go back and show you a picture of a normal chest x-ray, so testing, hello. Hi, sorry about that. I seem to have just been disconnected, but it's come back on now. Can everyone hear me okay? Okay, don't know why that happened, sorry. So, as I was saying, the diaphragms. In a normal chest x-ray, the diaphragms, if we just draw them out, are nice and rounded. And nice and rounded like this. There we go. And whereas in this patient with emphysema that we were just looking at, nope, not this one. This patient with emphysema here, the diaphragms are quite flat. So what you're looking at is the diaphragm. If you imagine you're looking at a 2D picture of a three-dimensional sort of person. So you look at, this is the back of the diaphragm, this is sort of the front of the diaphragm, and so it's quite hard to kind of, if you imagine this is a dome, the dome kind of starts along here and then it runs up through here. So this is sort of a three-dimensional dome. If that looks clear, can you see that? It looks like a three-dimensional dome. That's what you're looking at, and it looks quite flattened out. Whereas the last hilar we saw were the last diaphragms that we saw were nice and rounded. So you can see this patient's got dark black areas, flat diaphragms, and the last thing is when we counted how many ribs you could see, he's got really hyper-expanded lungs. So look how huge these lungs are. So they're not actually big lungs. It's a case of the lungs have been destroyed effectively. So it's just air that's filled up the chest wall. So his chest cavity is just filled with lots of air. And so if we count ribs, we said the sixth rib should cross the diaphragm here on the sixth rib. But if we count how many ribs he has, one here, it's rib 2, it's rib 3, rib 4, rib 5, rib 6 is all the way up here, rib 7, rib 8 is crossing the diaphragm. So you can see he's got far more ribs because he's got a hyper-expanded chest. So being able to spot emphysema and when you look at the lung fields is very, very common because lots of patients have been smoking for many years. And the three things that we said: dark lung fields, flat diaphragms, and hyper-expanded chest with really big lung fields. So the other things, increased intercostal space. So, yes, you can, because of the fact this patient's chest wall is big. It's more the fact that there's a large chest, but because there's a large sort of lung field, the gap between the intercostal spaces will also be bigger, just because everything's stretched out. So yeah, that is true. Right, so this is another chest X-ray where we're still looking at the lung fields here. We haven't moved on from that yet. So let's put up another poll. where is the problem? Is it on the left or the right? Good, so problems on the left. And this is something, so you can see, this is called consolidation. So you have, let me just get rid of this. So you have, start at the top. This part looks pretty much the same as this part. It's not too bad. They look kind of similar. To this part, this is nice and clear. Then here, there's lots of fluffy white stuff. If you go down, it looks nice and clear. And then here, there's lots of fluffy white stuff. And what this fluffy white stuff is in the air spaces of the lung, so the alveoli, where the gas transfer happens, where you should be having nice air going in and out of the lung, it's all filled with something. Most of the time, that something is pus. So if somebody gets a pneumonia, you have lots of inflammation, lots of pus cells and fibrin and neutrophils, all those sort of things which form the pus, all collects inside the lung air spaces. And because pus is thicker than air, it stops the X-ray beam, and so it gets white, doesn't go through. Whereas this is air going through nice and easily, the pus stops the air coming through. You can't, from a chest X-ray, tell that it's pus. It's the most common thing that it will be, but what you can tell is there's something inside those spaces. It's either going to be pus, water, or blood. There's not really anything else that's going to be doing that. And so if, say, in this patient, he had a high fever, a high temperature, he was coughing up lots of green sputum, you did his blood tests and he had raised inflammatory markers, so a raised white cell count, a raised CRP, and he was a bit short of breath, and you did a chest X-ray and you saw this picture, what would you think, what would that tell you this patient's diagnosis would be? So someone with a high temperature, coughing up sputum, and a chest X-ray that looks like this. Good, so it's a pneumonia. Very good. So a pneumonia, by definition, what that means is there's pus inside the alveoli of the lung. So there's pus in the air spaces. And that's how you can tell this is pus rather than water or blood. They'll all look identical. If it was pus, if it was water, if it was blood, it would look the same. But because it's a section and the patient's clinical picture makes it sound like he's got an infection, this is enough for you to diagnose a pneumonia. Telling which section pneumonia is in, which lobe, is very, very tricky because, as we said, you can't. It is a bit possible, but it's a lot of the time not possible because you can't tell where the different lobes, the divisions are most of the time. What you can do is divide them into zones. So you could say his upper zones are clear, and what we would say is this patient has a lobar pneumonia that's involving the left, middle, and lower zones. There is consolidation in the left, middle, and lower zones, and this would be consistent with a pneumonia of the left base and middle section. So good. And what about this one? Let's divide it up into sections again. I'll give you options, and we'll say, is it on the right or the left? Yep, so everyone said it's on the right. And is it in upper, middle, or lower? Yep, everyone said it's in the middle, right middle zone. So you can see here, this fluffy white bit is the problem. So again, we use our system, compare right and left. These bits look about the same. This is all white and fluffy, whereas this is nice and clear, and these bits look about the same. So what we've got here is, again, fluffy white stuff in a patchy section. It's going to be some form of consolidation, and most of the time that will be a pneumonia. In this case, this patient has a right middle zone pneumonia, and because it's so clear that you've got such an isolated middle section, you can probably be confident in saying this is a right middle lobe pneumonia. All right, so that's all the lung fields. Any questions about that so far? So just to recap, we've done trachea, we looked at the mediastinum. So the trachea, is it being deviated to the left or the right? Are there any tubes or foreign bodies in it? Look at the mediastinum, is it enlarged? Look at the heart, are there nice, crisp, clear edges, or is the heart enlarged? Look at the lung fields, are there any coin lesions? Is there any signs of COPD where it's dark with big hyperexpanded lungs and flat diaphragms? And looking to see, are there any patchiness of fluffy areas where it's consolidation? So the next thing is we go to the hilar. Hilar are actually very difficult because they look so different in different patients. It takes a lot of seeing lots of normal chest x-rays and lots of patients' chest x-rays before you can be confident in looking at the hilar, but you can kind of get a rough feel for them. This is a normal patient's hilum, but they can often look very different. So the main thing to recognize with the hilum when you're starting off looking at chest x-rays is to spot one particular pathology. There are other things. So as somebody mentioned before, you can get big hilar lymph nodes that can be swollen. If you get that bilaterally, that can often be something like sarcoidosis. You can get cancer metastases, you can get TB, lots of things that can do that. But that's something that is a bit more advanced, it can take some time. So to start off with, what we'll look at is this. So this patient, does anyone have any idea what's going on with this patient? So Mohammed said embolism. Any other ideas? Acute respiratory distress syndrome. Anything else? Okay, so a couple of things about this. Let's start off with looking at the basics. So if we go back to our system, remember the first thing we looked at was the technical details. And this patient's got an AP x-ray, it's not a PA chest x-ray. So this patient is lying in bed, and they took the x-ray from the front looking to the back. And you can see there's lots of wires sort of sitting around. Patient's head is over here. Looking at the technical details, he's rotated because his clavicles are sitting like this. He's not taking a very good breath in. All of these things together show you this is a really sick patient. This is not a well patient. He wasn't well enough to stand up, and that's why it's an AP x-ray. Supine means he's not standing as well. So it just shows you that this patient might be in an ITU setting, was probably in a hospital bed. He's a really sick person. Now, we mentioned embolism. There are some subtle changes you can get with embolisms, but almost all of the time, the vast majority of the time, if the patient has a pulmonary embolism, chest x-ray often looks normal, unless they've got a big wedge infarct that's so big that it's managed to kind of kill off a big chunk of the lung. Most of the time, a chest x-ray and a pulmonary embolism looks normal. The way you diagnose a pulmonary embolism is you use something called a type of CT scan called a CTPA, which is a CT pulmonary arteriogram. But that's something we can look at later. But from a chest x-ray, it's normally it's almost impossible to spot embolisms on a chest x-ray most of the time. In terms of ARDS, ARDS is something called acute respiratory distress syndrome. And what that is often if somebody gets, if they're very unwell, if they get exposure to various toxins or chemicals and things, they can get a big inflammation of the tissues of the lung, and it can cause lots of edema and fluid to build up. Now, this chest x-ray could potentially be ARDS, but ARDS is very specific. It's telling you what the cause of the problem is. So in this chest x-ray, what we're looking at is something called pulmonary edema. And pulmonary edema is often known by, you can recognize it by bat swinging. It looks like a bat. So if you look at this, his hilar, remember the clear hilar of this patient, which is a nice and normal hilar. This person's hilar, you see it's all fluffy coming out from the edges. Lots of fluffy stuff that's all expanding out. And what that is the vessels have become really blocked up, and they're really full and swollen with fluid, and the fluid is leaking out, and that fluid is blocking the x-rays, and that's giving you this white fluffiness. And it's called a bat swing appearance because it looks like there's a bat coming from the center, and these are his wings coming out. It's called bat swinging. And this is very classic of pulmonary edema, which is, as I said, fluid coming out. most of the time, that the reason for that buildup of back pressure and fluid leaking out of those vessels is because there's some patients got heart failure. So their heart isn't able to pump the blood from the lungs to the rest of the body. So the pressure in the lungs builds up and all the fluid builds up in the lungs and you get this pulmonary edema. You do get, the main feature of ARDS is pulmonary edema. So this could be ARDS, but it's more likely, well actually it's impossible to tell from the x-ray what the cause of the pulmonary edema is. Options would be things like heart failure, if they had pleural effusions and a large heart. ARDS is another option, but smoke inhalation, lots of things could cause pulmonary edema. But basically what you can tell from the x-ray is that it is pulmonary edema, and then from your clinical picture about the patient history, the examination, all the other factors that were going on, can tell you what the cause of that pulmonary edema was. But the main thing is just to be able to spot fluffiness in the hilum coming out from the middle. That is pulmonary edema, and it looks like the wings of a bat. Right. So HILA, as I said, are very hard, but with time and experience, the only way to learn it is by looking at lots and lots of chest x-rays, and eventually you get a feel for what kind of looks like a normal hilum and what doesn't. But starting off, pulmonary edema is the main thing to look for. And I'll type that out in case... pulmonary edema, in case anyone wants to spell it. Okay. Right, the next thing is you look underneath the diaphragms. So, as you can see in this healthy patient, diaphragm, you have lung here, and then it becomes a nice, clean, crisp diaphragm, and it's nice and it's nice and solid all the way across. So this is a normal person's diaphragms. The main thing, so we mentioned before in COPD people can get flat diaphragms, but that's a chronic problem that's, you'll see with the rest of the picture, it'll be a bit more obvious that it's COPD. The main single thing to look for with the diaphragms is you look to see if there's any air underneath the diaphragm. And does anybody know what air underneath the diaphragm tells you? Any ideas at all? Guess. It's fine to guess. No one going to be brave enough to guess. Free air in the abdomen. Exactly. So, good. So, you can see on this patient, these are the diaphragms, these lines here. This is the diaphragm. And this is the diaphragm up here. And you can see that there's this air space. Look at all of this air that's collected. So these are his organs. So this is his liver and his bowels and things. They've all been pushed down. In the healthy patient, there's a nice clear edge. You can't see that the diaphragm is right against the organs. There's no air space. Whereas in this patient, you've got your big air spaces. And that is exactly what you've all said. It shows that there's free air in the abdomen, which means the patient's had a perforation. Again, from this x-ray, you can see this is an AP sitting x-ray. So this patient wasn't well enough to stand up. So he's, again, a really sick person. He might have had an operation on his bowels. He might have had inflammatory bowel syndrome that's perforated, a cancer that's perforated. Just the colon, the bowel lining has had a hole made in it, and the air that was in the bowel has now leaked into his abdomen and has made him very unwell. And the best way to spot that as sort of a quick, rapid approach is doing an erect chest x-ray, and if you see free air under the diaphragm, that's again another emergency and something that you can't miss. Because if you don't spot this, then this patient can get very, very sick very rapidly and often can die. So you need to be able, and they need surgery to correct that perforation, antibiotics to protect them from the other things. In addition to air that's leaked out, other bowel content might have leaked out into their abdomen as well. So it's a really important diagnosis to spot. And that's the main thing that you look for when you get to the diaphragms. Right, so again to recap, trachea, is it in the middle? Mediastinum, is it swollen and enlarged? Heart, can you see the heart edges, and is the heart enlarged, more than half the width of the chest? Looking at the lung fields, comparing the upper, middle and lower zones right to left, are there any coin lesions? Is there any emphysema? Is there any consolidation that might suggest pneumonia? Looking at the hilums, is there any evidence of pulmonary edema? And looking under the diaphragm, is there any air under the diaphragm? And the next section across this is what we're coming to now, which is looking at the angles, which are the costophrenic angles. It's these sections here. And as we mentioned before, the costophrenic angles are just the point at which the chest wall touches the diaphragm. And the key thing to recognize is that costophrenic angles in a healthy person should be sharp. Can you see it makes a nice sharp pointy edge? What you want to be able to recognize is when that sharp pointy edge like this becomes blunted. So you can see here on this side, this is not a sharp pointy edge anymore, it's all been blunted. And what that tells you is that, so this side is nice and pointy and normal. And what that does is it tells you that this person's has fluid has collected inside the pleura, which is the lining of the lung. So outside of the lung lining, there is fluid that has collected and has blunted these edges on the right-hand side. So this is called a pleural effusion. In another tutorial, we can go through the various causes of a pleural effusion. What a pleural effusion, basically, it can be things like infection or inflammation or cancers or fluid leaking out because they have heart failure or renal failure or liver failure. There's lots of causes, but there's a way to approach the differential diagnosis of a pleural effusion. The first step, though, is on a chest x-ray to be able to recognize the pleural effusion. And the way you do that is by seeing that there is a blunting of the edge on this angle. Good. Any questions so far about any of that? Okay. So we're nearly coming to the end of our system now. So well done for making it this far. It's just a couple more bits to look at, and then we've done our complete system of how to look at chest x-rays. The next step is the pleura. And what the pleura is, as we said, it's the lining of the lung, and we're looking at where it meets the chest wall. You can see in this person, in a healthy person, it's a nice, neat edge where the pleura touches the chest wall. There are lung markings that go all the way up to the edge, so you can see these white bits here. This is all vessels and things that are in the lung, so you can see that the lung markings go all the way up to the edge. There's no air that's collected, there's no sort of the lung coming away from the edge of the chest. It's all nice and clear and healthy. What you want to look for, and when you look at the pleura, is something like this. So this person, as you can see here, this is the edge of their lung has come away from the chest wall. This is what we call a pneumothorax. And that means there's been a hole in the lung that has let air escape from the lung into the chest wall. And you can see here, this is all completely black. Whereas if you look here, you can see the lung markings. There's lots of white grey bits. This is the vessels and the tissue of the lung. There's none of that up here because this is just air. It's completely perfect air. The lung is all the way down here. The other thing that you look at with the air, so is this really crisp, clear border. So that's the edge of the lung. So this is something that's often very tricky to spot if it's a small pneumothorax, but this is how you make that diagnosis of a pneumothorax. A really important thing to be able to diagnose, so you have to be able to spot this on a chest x-ray. If you can't do it initially, then don't worry, but it's something that with practice that by the time you become doctors you'll be able to do. So is the problem on the right or the left? Okay, so we've got a bit of a split. Most of you think the problem is on the right, some think the problem is on the left. So remember, we go back to our system. So we'll look at the trachea. Trachea is sitting here, it's nice and central. So it's not a tension pneumothorax, because that's what happens when the pressure builds up. This is the difference in a tension pneumothorax and a simple pneumothorax. Tension is when the pressure builds and pushes the lung across to the side and is a medical emergency that has to be dealt with within minutes. Whereas a simple pneumothorax just means air has escaped, but it's not building up. There's no valve that's causing the pressure to keep increasing. So the patient is okay, but they will need management eventually, but it's less of an immediate emergency. It's still very important. It needs to be dealt with very quickly, but not within minutes like the other one. So the trachea is central. Look at the mediastinum. Looks normal. It's a nice aortic arch that you can see there. Look at the heart. You can see a crisp, clear edge here. It's a bit hard to see this border here, so there might be a bit of something going on here. But the heart looks about, width-wise, it's less than half the width of the chest, so that looks okay. We look at the lung fields as our next section. If we look up here, compare this bit of the lung field with this bit, they do look a bit different actually. So this one is, there's not much you can see here. There's lots of like lung markings and white bits here, but it looks very kind of, I can't really see anything here in this part. Come a bit lower down, this part looks again quite empty, but here there looks like lots of lung markings again. So I can't see any lung markings at all on this side. Come a bit further down, same sort of thing. So there's some lung markings here, but then there's this sharp edge. And there's no lung markings across here. And again, there's no lung markings here, but there's lots of lung markings here. So it's always about comparing right with left every single time. And the thing to be able to notice, we have two things. No lung markings at all along this outside edge. And also, you can see this sharp line that's going across. And we can mark that out like this. So this is somebody who's had a big pneumothorax on the right-hand side. So this bit is all air that has filled up and collapsed this lung down into this section. It's not a tension pneumothorax because the trachea is in the middle, but it is a big pneumothorax. So this lung has been all collapsed completely, and this is all filled with air now. So this is a pneumothorax. And yeah, the right lung is compressed right down into the bottom, you can see. But don't worry if you can't spot that to start with, but that's something with practice and looking at lots of x-rays, you'll start to get the hang. But can everyone see that now, that there's no lung markings at all here, but there's lots of lung markings here, and you have this nice clear edge. So that's how you recognize a pneumothorax. Is everyone happy with that? Any questions about pneumothorax? No? Okay. And the very last step of our system now. So this is the last bit, and then we're nearly done. So once you've looked at all the different bits of the lung, the next important thing to look at is the bones and soft tissues. And it's again really important to look at these because it's so easy to miss problems. A lot of the time, something can be looking right at you at the x-ray, but because you're focusing all your attention on things like the heart and the trachea and the lungs, you miss the really obvious fracture or the really obvious break. Now what I'll do for this one is a little bit tricky, so it might be quite hard to spot. So let's do another poll. Is the problem on the right or the left-hand side of the x-ray? So people are voting. There's two people haven't voted yet. Do you want to guess? Doesn't matter if you get it right or wrong. It's quite hard to see. Oh, it's about 50-50. One last person hasn't voted. Okay. Alright, so let's put this up. So, half of you think it's on the right, half of you think it's on the left. And that's completely reasonable. This is a very difficult x-ray to spot if you're just starting out with x-rays, so don't worry about that. But again, let's go through things as a system. So the things you can look at that can break. Clavicles can be broken sometimes, so what you want to do is look at, are they nice and straight edges? They both look, you can follow the edge, what we call the cortex of the bone, all the way across, and it all looks nice and solid. It looks like a nice bone on that side. Look at the clavicle on this side, that looks nice and solid. Good clean edges, it's all crisp. So that looks okay. Let's go through the ribs. So look at each rib in turn. So this is rib 1 coming down here. It looks nice and normal. Rib 2, rib 3, 4, 5, 6. Can't see any breaks on any of those. That's the anterior parts. If you look at the back part of the rib, it comes around here, so that looks normal. These ribs, see the edges of all these ribs? They all look nice and clean and sharp. Again, I can follow this rib all the way around. I can follow the line. What I can even do, let's see if we can get this to work. I can zoom in a bit. Yeah, that's it. So, oops. Right, so if we look at these sections, all the ribs are nice and clean, so I can't see any breaks on that side. If we look here, so this rib, nice and sharp edge on this rib. This one I can follow the cortex line across, follow that all across, it's fine. Now, what's happening here? Can you see this? This rib comes up, and there's a bit of the thing here, and then this bit joins it here, so this rib's broken. Can you see that? Same as we come down a bit further. I think this rib can't quite follow the markings very well. Here, can you see this? It comes through. Doesn't quite look right. So I think there are fractures of these ribs here, especially this part. So I think this section has got broken ribs. And the other thing you can tell from this x-ray, he's broken more than one rib. So whatever it was, as we come here, it gets even more obvious. So here is really big. If you look through this bit, you see that? Now these are clearly here. There's a massive group of fractures on the ribs. So let's zoom in a bit, make that clearer. So can you all see that these ribs are broken? And that's something that's very, very easy to spot on a chest x-ray. Lots of people miss these fractures. So the key thing here is just seeing that this is completely not in continuation at all with the other half of the bone. It's very easy to spot these fractures, to miss these fractures, sorry. So that's why it's important to have a system so that you can pick this up. So here, that is clearly a break. Okay? So, just to recap, look at the technical details of the x-ray to make sure that you got the right patient, how the x-ray was taken, that all the bits of the x-ray are in the right picture so that you can read it properly. Look to see if there are any foreign bodies, things like NG tubes, and then lastly go through the 9-point system where we start at the top in 3 sections and we just look from the top to the bottom each time, and then you should pick up all the different details and problems. So that's a kind of quick run through the system of how to look at chest x-rays. If you have any questions about any of those, we can go back to slides and look at them and talk about them a bit more. Or if you're happy with that, then we'll be able to do some more tutorials later on. But for today, I think that's everything that we're going to go through. Can you see bone sarcomas on chest x-ray? So you can see what I can do actually is I can probably send you some pictures. So you can see, you can't diagnose a bone sarcoma from an x-ray, but you can see masses on things like ribs, in sort of metastases into the lungs, metastases in the lymph nodes. So you can recognize that there's a problem there, but spotting a bone sarcoma and diagnosing it as a bone sarcoma, you need to do a biopsy and things to do that. But you can see sort of tumors and things. Try and see if I can find a chest x-ray with a bone tumor. So there aren't any very good images of this, but we can go through that later if you want. But it's more a case of spotting the problem, and then diagnoses come afterwards. It's with the whole clinical picture. The chest x-ray is just one feature of that, and the key thing is to recognize there is a problem, and then you use that with everything else to diagnose the kind of full picture. So yeah, as Keenan just typed there, we're kind of building this up still, so it's still our early phase. We're sorry that we had our small problem with the delay to start with, but now it looks like everything's running quite well, so we've learned from that, and it should work on our next tutorials, should work much, much better. What we want to do now is if we can get an idea of, I know people at the beginning mentioned some things about where they were and watching. We just want to get a bit of data about who's been watching. Sorry, we just lost connection again. But yeah, so we just want to find out whereabouts, so we can check if we've got different regions are being covered to see if you're getting good enough internet connection there, and how many people we managed to get our tutorial out to. And yeah, the last thing, we're trying to promote this within England to get more and more doctors and experts and academics involved so we can help you guys out better. And one of the things that people appreciate is to see kind of pictures of the students enjoying the lectures and learning from it. So if you're happy to send us a selfie or anything, of photos of you guys sitting around computers learning from the lectures, then we'd appreciate that, and we can share that with the website and get a bit more support and things from people here in the UK. So if you're willing to do that, then you can send us an email with a selfie picture. But well done for making it through. It's been quite a tough lecture. We covered a lot of material, and congratulations for being the first group of students that we've managed to run this multi-connection feed with. So hopefully it's the start of lots more lectures to come, and we can help you guys out some more. I hopefully found that all very helpful. Great, well I'm glad you all enjoyed it. We'll let you know about the next tutorial, but until then, thanks very much, and hopefully we'll see you all soon. Goodbye.